Right, so welcome again back to the stage, and is everyone squeezed in? And a special welcome to Cyrena, who has not been on the stage yet for part of this session. One of the things that we want to do in our conversation right now is keep pressing on this question of what precision education means and could mean, especially to the diverse stakeholders that we have up here and that we have in the room. And so, Cyrena, I wanted to ask you to start us off, because I know from our conversations that you have many insights as both a former student and as a patient about what this could mean. So could you start us off by just telling us a little bit about your experience?
Yeah, sure. So I am what one of my advisors called homozygous Brown. So I went to Brown University for undergrad, my short stint in medical school, and my PhD. Getting more to your point here. So I started out, I wanted to be a physician since I was 10. I was actually said I wanted to be a neurosurgeon. Okay, great. But that kept going. And when I got to undergrad, I actually was in Brown's 8-year BA MD program. And at some point during that period, I decided I wanted to do a PhD as well. So I started the MD PhD program at Brown. And during my first year, I had started having some problems with my health. So before I started medical school, I had been diagnosed with bipolar depression. That was, it was under control, it was fine. But when I got into medical school, I started having, episodes again. The problem with medical school is that everything, at least at Brown, it was lockstep. Organ system, you do pulmonology, you do cardiology, you on and on. So if you miss a couple weeks, you've missed everything. So I had to redo my first semester because I missed a couple weeks, and that threw everything off track. And during the course of my second year, I was diagnosed with lupus. So again, I wasn't doing very well because I was very sick. But no one knew that. I walked around with a hat, and I covered everything up, and no one asked what was wrong. And so I started failing again. Now, keeping in mind, obviously, I was not incapable because I got into the MD PhD program. It's not a matter of intelligence. It's not a matter of capability. It was just a matter of illness. And again, it's not flexible. Mm-hmm. So I got into a position where it was the decision either you leave or they kick you out. Well, we all know leaving is much better than being kicked out. Mm-hmm. And the thing is, though, we talk about clinical skills a lot. The clinical stuff, I was fabulous at it. Everyone said, you are so great. I would get things out of our standardized patients that no one else got out of them. Mm-hmm. When I was in the clinical setting in the community, we had a half day a week. We'd go into community settings. People would tell me everything. They would tell me things that they wouldn't tell their physicians. Mm-hmm. So it wasn't, a matter of being unable to work with patients either. It was simply medical school did not accommodate illness. It did not accommodate disability. So I left. I was, thankfully enough, the department that I was going to do my PhD in said, we'll still take you. You had a spot. And I managed to have a comparative experience with illness. So in graduate school, I started out in an electrophysiology lab. So I was doing patch clamping. And if you know patch clamping, you have to have a very steady hand. You take lithium, you do not have a steady hand. And so I worked with my psychiatrist for a while, and I said, I really need to do this. Can you figure out a way to help me do this? And we came up with a way. We lowered my lithium. I started taking a atenolol, which helped with the tremors. But the fatigue from the lupus cut off that electrophysiology career. You can't do 12, 14-hour days if you have lupus. You know, I remember crawling around on the floor because we were having problems with our rig. You can't really do that on a day-to-day basis. So here's where graduate school worked better. They accommodated me. They said, okay, we know you can't do this type of work. Let's find something that you can do. So I ended up in a translational neuroscience lab in psychiatry. And when I was sick, I had the capability of stepping back, reading journal articles, and then coming back into the lab. I was an independent worker. So if I had the energy to run ELISAs for like 14 hours, I could do that. And if I didn't, fine, I run statistics instead. So that was a really comparative experience between medical school, which was very inflexible, and graduate school, which was much more flexible. I mean, even in the terms of education, you took classes in the things that you wanted to study for the long term. It wasn't like everybody takes exactly the same thing. And you know, there was a major event that happened when I was in graduate school. So I actually had transverse myelitis, and which is, for people who don't know, it's demyelination. Oh, that's a word too. It's damage to the spinal cord. And you know, it came on suddenly, and I was paralyzed on the left side from the chest down, and I had neuropathy on the right side. Some people might know exactly what I'm talking about. And I was out of grad school for like 3 weeks. Completely, you know, 3 weeks. I was in the hospital, and then I was in inpatient rehab hospital. And another difference was one of my advisors came to the hospital to see me twice. You know, nobody knew what was happening when I was in med school. You know, all I said was, I'm out because I had, you know, an injury. They came to see me. You know, they cared. And when I got out, you know, how are you doing? What can you do? And I remember very vividly, you know, I was in the inpatient rehab, and one of the things that you know when you're in rehab is that it's a lot of older people. So the next youngest person was about 30 years older than me. Fine. So I didn't exactly have a great social experience there. And I asked one of my friends, bring me my laptop, because I have so much downtime. I need something to do. I was able to do my work in bed because of that flexibility. You know, and when I got out, I had a committee meeting. No one said, hey, I don't think you're capable of doing this because you're on a cane. Why don't you just sit down and do your presentation? That's fine with us. You know, that is not something that I think would have happened in medical school. So I managed to graduate because I had support. I had people who cared. You know, I'm not saying that's a universal experience, but in my case, I had people who cared. That were the, you know, chair of the department all the way down. They supported.
Yeah. There's so much in your story that speaks to so many of the themes of the talks for the session, and I think one thing that really stands out to me is the idea that what we might call precision education, something that is perhaps more tailored to the actual individual student, both in terms of their needs and their interests, might actually allow people who are typically excluded from medical education to become doctors and other kinds of health professionals. And I'd like to open it up to the panel a little bit right now to ask your take on this, if anyone from the couch would like to comment, because it seems that the question of the gap between how medical education is delivered now and what students actually want and who we want to get into that system also is there's so many disconnections there.
Yeah, I'll throw out some ideas real quick. I mean, one of the big, so I'm a new parent. I have an 8-month-old at home, and for anybody that has an 8-month-old, that's it's a busy job. And so my hats go off to anyone that has more than one kid, because I can't imagine how that's possible. But So for anyone that's thinking about medical school, but let's say you have a child at home, or two, or three, or you have a parent that's sick, like how do you balance that? That's very, very hard if you have a bunch of lectures you have to attend or a pulmonary block like you're talking about. That's a very lockstep approach. And I think that as you start loosening the reins on that and say, hey, we have this awesome experience where we're going to invite a patient to come and talk about her experience on having lupus and bipolar and kind of navigating that. It's going to be Tuesday night from 8 to 9 or something like that. We have this other experience on Monday morning from 7 to 8. People can start kind of picking like a menu, kind of what they want to go to and what they want to attend. And then they can kind of balance their schedules around other things and say, look, I can go and learn all this other stuff. It takes all the lecture stuff out. I can do that myself from a laptop at home, but I can go and have these really powerful in-person experiences. I think if we really kind of surgically go through a schedule of like what students are getting in class, you can kind of extract a lot of that stuff and say, look, this is stuff you could do at home on your own time, how you want to fit it into your busy schedule. You can all of a sudden invite new people to the table of medical school that otherwise would have no shot at it.
Lots of stuff you could probably just totally throw out as well.
Yeah, absolutely. Yeah, absolutely.
Yeah.
And stuff that's thrown out that you could probably bring back. I mean, you just have to renegotiate all of that.
If you just give learners a goal, if you give them a reason to learn, like people who go into these fields have hungry brains. People want to learn stuff. Let their curiosity be their motivation. And they'll find the stuff, as long as the material's available and they know where to find it.
I do think you need to deleverage the student from the classroom significantly in medical school. We're starting to see that change more. That has to happen at a much more rapid pace. And also we have to figure out a way so a student can interact in the classroom if they're in a hospital bed or they're in a location where they can't do that. And I mean, 3 people here on the couch are talking about mechanisms to do that. So you're seeing that ball move, but it has to move at a much faster pace. We're talking hundreds of thousands of healthcare workers short. If we lose people like this, it's a detriment to society.
It's a huge loss.
As a medical student, you know, it's true that you have all of these tools available to you. It's an ever-growing library, and you know, personally, from my experience so far, at least half of my class doesn't go to lecture. They'll watch it at home, 2-speed, and just like millions of other medical students around the world. And what we are missing or really need is some help from the faculty to help curate that or tell us what is the best option for us. I mean, there's just this paradox of choice where we have so much available to us, and it would help to have some sort of like peer mentorship or one-on-one coaching on here are the best ways to get this type of knowledge. And on top of that, not everyone learns the same way. I like to do drawings. My other friend likes to read the anatomy textbook and get the text, version of it. So being able to tailor to the way that individuals learn would be good.
So there's a question about delivery mechanisms, but there's also a question about content. And we were talking about this a little bit yesterday, Cyrena. You had some interesting ideas about what different kinds of content might need to actually be more emphasized in medical education to sort of create the kinds of doctors who, as educators themselves, might have had a different relationship to a student like you.
So, we had a very long discussion, so I'm trying to find exactly what that point was. But I think that, as a patient who has gone through part of the training process, the most important skill that medical students need to learn is engaging in a clinical environment. You can be excellent at passing your OSCEs. You can be excellent at passing all of the basic science blocks. But if you can't interact with a patient, you are a failed doctor. Your patient leaves. And I have this one anecdote that I remember very clearly. So we used to do what they called the behavioral and social stuff. They called it doctoring. And we had one session where we was talking about weight loss counseling. And the case study, it was a person who was 100 pounds overweight. So the question opens, how do you counsel this patient? We had a student who raised his hand and said, you tell them that if they don't lose weight, they're going to die. That is a failed doctor. And by the way, that guy ended up going into plastic surgery, so I guess, like that followed anyway. But I think that's the most critical thing, the most important thing to learn, because all the other stuff, you can read it. I mean, Let's be honest. You don't have to go to class because you can read it. The only classes that I remember people went into med school were the ones that were done by the basic science, like professors. All the clinical stuff, they just put on PowerPoints. There you go. You just read the PowerPoint. You didn't have to go to class. People used to sleep in the back. You know, but the clinical things, you have to engage, and I think you have to engage as early as possible.
I was going to say, I'm going to add
Yeah.
to that. I think the cultural competency of clinical education is paramount early on in the medical education. And I'm going to give an example of myself. I live in Missouri. I'm a Midwestern Catholic boy. If I have a heart attack and I go to the hospital, a doctor walks in the room, it's my wife and me. So he's got to interact with us. I work in Puerto Rico. If a patient has the same physiology heart attack and I walk into that room, there's 25 people in that room. Now, medically, what you do to the patient is the same. You know, how are you going to treat the patient? But culturally, how you handle that, if the doctor does that to me, I'm Irish Catholic in the Midwest, you don't touch me. There's no reason to touch me unless you have to. But down there, it's an important part of developing that patient bond.
Yeah.
And understanding that early on in the clinical education, I think will also help them pass. Unfortunately, we have to pass step one. Understanding that cultural aspect, understanding that skill set clinically helps them cement the basic science knowledge so when they go take the boards, they can develop those relationships and be able to answer the questions.
Right.
I had a student who was having some communication troubles, and it came down to really not expressing sufficient empathy, which is similar to what it sounds like you experienced that a lot, and that guy in your class, obviously, too. And I was having a really hard time trying to connect with him on the idea that, like, this is a central concept to interacting with other human beings in the world. and that's fine because not everybody knows, that doesn't connect naturally to everybody. But I do think you can be a good doctor if, and I wonder if this is going to go over super well, if you fake it. Because all I did with that student was I said, look, you don't have to care. Just when they tell you the first thing they tell you, and they tell you that it is awful, I want you to say, wow, that seems hard. And then let them talk for as long as they talk, and then you can ask your question. And the patient came up to me afterwards and said, your student is really great. He listens so well. And like, he really doesn't. But it sort of worked, you know, for the first time, that sort of seemed like a relatively reasonable first step, faking it.
Mm-hmm. Would anyone else like to respond to that idea of faking it?
We had a discussion a little earlier about the concept of whether or not you could actually teach empathy.
Right.
And I remember in our doctoring classes, we learned clinical empathy, which is exactly what you were talking about. You learn what to say in particular situations. Oh, that sounds awful. Can you tell me more about that? What would you, some people have that naturally and some people don't, as you mentioned.
That's how we do it. Like, that's how human beings do everything.
Yeah.
We learn how to do stuff first, and then we figure out why it's important later.
Right.
And we don't think of it that way. We always think that we're doing it the opposite way around, but I think that's maybe a fallacy in our own cognition.
Yeah, I totally agree. I think the idea of fake it till you make it just makes sense in so many contexts, especially this one. And I think I was actually kind of expressing this idea when I was a medical student. A lot of my classmates said, hey, you just got kind of annoyed with all these empathy classes, or they're rolling over their eyes, like, why do we need to do this? And you can't teach someone to be nice. You can have, like, be a good person classes. And actually, I think you can. To be honest, I think you can teach a lot of these skills. And there is a certain aptitude that you walk to the table with, but then you can go much further given the right sort of training. And parts of that training are to model the behavior. And when you say model the behavior, that sounds better than faking it, but it is faking it. And once you model it, you start recognizing that there are pieces of that you can kind of resonate with. And then it starts becoming more natural.
But the problem is, coming from the dean's perspective, we have a lot of stuff we have to put in a curriculum for a medical student. How do we is that a valuable piece? And I think it is. So I'm just posing a question. Is that a valuable piece to put in the curriculum? And if so, the students only have a certain amount of time. What do we pull out?
Yeah.
Because there's certain things that are going to have to come out to make that occur. And
I think Clay's got answers in terms of what to pull out.
Yes, very good.
It's like 90% of it.
Not all this learning has to happen in school or during school time. You know, I mean, you can be an empathetic person and learn that when you're talking to preschoolers or ordering a hamburger, or if you're off in a different country helping someone else. You know, I mean, there's many ways of doing that. So enabling students to have those types of experiences, go and live in a different country, for example, or invite someone from a different country to live with them, and just be with them, have them sleep over with you, go to a movie with them. I mean, whatever it is, or like hear about their real serious tragedy that happened to their family. You know, those are ways to slowly over time, like, what does empathy mean? It's like taking on someone else's suffering and, you know, feeling it as your own. So just, you can do that in a school or also outside of a school.
Yeah, so I wanna ask the three of you actually, because in your talks there was a lot of emphasis on the very creative ways that you are using technology and data to tackle part of this question of the mismatch between medical education as delivered today and the medical learner, right? But is there a role for the data and the technology to play in creating more space for, or creating better mechanisms for, helping students get in touch with what we've just been talking about, the kind of cultural connection, the kind of empathy, or the human parts of doctoring?
I guess I'll answer that first, and this isn't going to be a very popular answer. We get thousands and thousands of students applying for 100 slots. And what we've done with the data is we've changed our admissions. I'm looking for that empathy as part of the admission cycle. That 4.0 that, you know, is just off in the corner isn't the student we want anymore. I'd rather have the 3.3 grade point student who actually develops or promotes that skill set in the interview. To me, that's the doctor we need. And what we need to do is reevaluate the way we admit students into our school. And, you know, right now we're gauged as medical schools on how well we get our board passage rate. Well, it's great if you take the top 0.1% of the world's smartest kids into your medical school and you get 100% pass rate. That's not what we need. We need students who are going to pass the boards, but also have that empathy, because the reality is we don't have a ton of time to teach them. And if we can get them coming in with that skill set already, that's how we make our schools better, in my opinion.
Let me just follow up with you on that, because you had said in your talk that actually when you started changing your admission strategies that your board passage rates went up.
Yep.
So can you just tell us a little bit more about that?
So what we found is that the verbal score had no bearing on how well you do on your board scores. I mean, this is just a simple example. All medical school deans know this. I mean, but we still use this as a metric to entry. And I'm like, why? So we just removed that, and just by removing that, the applicant pool that we got to select from increased with more blacks and Hispanic students. Well, those students tended to have better skill sets in handling patients from their culture. They had a little bit more empathy, and so we were able to increase our URM count. Their bio score is what mattered and somewhat of a predictive element to their board scores. So we started taking more students with the higher board scores who were African American and Hispanic, and so our board scores went up. And these were students, the thing that I'm most proud of, these were students other medical schools weren't taking. They weren't getting into NYU and Columbia and Harvard. These were kids that were like, hey, you got what we want. You're going to go practice in the community. You're going to treat the patients that we know society needs, and you're going to pass the boards. And unfortunately, that's the reality of what we need to do. And I'll tell you, that was a big hit. That was really quite a significant change for us.
Do the other panelists have any thoughts about using data and technology to come at this problem? Often these things are seen as antithetical, right? Like you talk about the human part of medicine. People often see technology as actually interfering with that, but that may not actually be a real opposition.
I think it depends if you're using technology to make your work easier or to make your job more effective. And I know those sort of sound a bit the same, but using data to give yourself feedback as to whether or not you're achieving your personal performance indicators, like how many times did I interrupt that patient, would be a pretty solid one for somebody to click. You don't need technology. The technology you need is a stopwatch and a clicker to count, right? But that data would be super useful to a student who just interviewed somebody and interrupted them 8 times. And you say, hey, did you know that? And they're going to say, no, I didn't. And next time, they won't. I mean, they'll do it less, maybe.
Yeah.
Well, no, I mean, we have just a little bit of time. I'll just say very briefly, a lot of our content is also in the world of open education resources, which means patients get access to it. So one cool thing is that patients often leave vignettes, and they'll say, hey, I just saw this video on vasculitis or lupus or whatever. The first thing a student sees then is that vignette, and that's a very powerful way to frame that concept. So I think a lot of patient framing is a great way to kind of drive empathy, is to remind you why you're learning about that as well.
I think that's a great note to end on. Larry, any final thoughts?
Yeah, no, I think this panel has had some great insight, and I think I think Sarina's story is a great reminder to us all that if we're going to think about precision education as a way to make learning more precise for the learner, then we have to remember that learning takes place within the context of the whole person and the entire person's life, and that means we need to learn more about people if we're going to really think more about precision education. So I'll leave it at that.
Okay, great. Thank you all so much.